Okay. Okay. I begin in the name of Almighty God, most gracious and merciful. Good morning, afternoon, or evening, wherever you are in the world. Salams and greetings to everyone. Today, as we celebrate the Eid festival worldwide and enjoy the time with our family, I would like to wish you all heartfelt Eid Mubarak to all of you, and thank you for attending this webinar on Eid Day. Thank you. I feel deeply honored and privileged to welcome you on the eighth and final webinar in our series during my term from 2023 to 2025. Over the past 2 years, we have designed these 8 webinars in alignment with International Working Group on Diabetic Foot International Renko from Taiwan, who will be introduced later by our incoming president, Professor Harry. The sponsor's presentation will last approximately 10 minutes after the Sicco's lectures and Q&A is over. So with that, let me begin my slides. So can you see all my slides?
Yeah.
Yes.
Yeah, good.
They look great.
So, thank you. D-Foot International, a mission with a vision. Before I start, I would like to thank the board members of 2023 and 2025. Thank you very much to be with me till this end. And all the regional chairs, regional advisories, country representative, and full board, the D-Foot members. Thank you very much. I would also like to welcome the new board members of 2025-2027, which will be led by Professor Harry till 2027. So welcome to the board. D-Foot International is a registered international non-profit association under Belgium law. It is a global organization, consists of people working in the field of diabetes-related food complications. All are dedicated to providing food care, educations, and so on. These people are spread across 7 regions in the world. And as we all know, Sub-Saharan Africa, South and Central America, Middle East, North Africa, North America and Caribbean, Europe, Southeast Asia, and Western Pacific. So we have, this is a structure, D-Foot members, we have a board members, regional chairs, an advisory country representative, and then we have full members from all these 7 regions. Our mission is to promote the global profile of diabetic food prevention care through awareness, guidance, education, research, and professional development, ending avoidable lower limb amputations due to diabetes globally. Our goal is to prevent reduced number of unnecessary amputations from diabetes worldwide and to improve the quality of their life. Our focus of action is training the healthcare professionals, mostly focusing at the primary level, how to manage diabetes-related food complications effective and prevent amputations, giving healthcare professionals strategies how to implement and sustain the food service. And obviously, in most of the countries still, diabetic food specialty is not been recognized as a specialist. So to promote and recognize the diabetic food specialists, which we managed to do in 4 to 5 countries in Africa. Closing the gap of available and affordable diabetes food care. So just briefly, I'll go through the activities which we performed. Just picked few of them. The main flagship programs, we have trained the food healthcare professionals, which we train them and then they go and do step by step in each country, where whoever has come from. And then we have a World Diabetes Awareness Week, which runs for 8 days from 7th to 14th November. All these programs are there, and we have webinars, 18 newsletters, brochures, leaflets. We have research-oriented projects, course study. We did AFRODA, launching of fast tracks, training the surgeons. Partner organizations, all the list is there, you can see. And then we have managed to do 3 international conferences. We have infrared, which have been translated in different languages, websites, YouTubes, all the information, education informations are there, and so on. So flagship program, which we managed to do in this 2 years, was 5 of them. So the first one was in Southern and Central America, where 8 countries came into under one roof. And then when they went back, they did step-by-step food project. The second one was Western Pacific region. 14 countries came in Kuala Lumpur, Malaysia, where Professor Harry was doing that. Then the third one was European, where we did in Slovenia, where Wilma was heading this, and 10 European from Eastern European countries, they came under one roof. And the fourth one was in Sub-Saharan Africa in Zanzibar. 11 African countries came under one roof, and I was heading this. And the last one, the fifth one, was for war-affected countries from Middle East and North Africa. And Zahid was leading this. So this second is flagship program, where we do it for 8 days, all the regions from 7th to 14th November, and one we have a global meet. And this was where in 2023, 54 specialists came from 7 regions. And we had a global meet where David is there, is one of the speakers as well, where whole world come under one platform. And in 2024, 61 specialists came from 7 regions. So altogether, 115 in 2 years, they took part in this event. From this year, 16th November, we have managed to do it only one day, which will be full day, Central European time from 8 a.m. till 6 p.m. And all the regions will come under one day on Sunday. And that has been agreed and accepted that onwards now we are going to do it on one day. Webinars, as you are aware, 8 webinars were programmed for this year, and this is the last one, which will be closed by Professor Sicco A. And that's today. Newsletters, 8 newsletters are supposed to be come, and the one is going to come next week, which will be the final one. Several 8 brochures, leaflets for the education, which was in collaboration with Royal College of Podiatrists and Food Diabetes UK. Research-oriented projects were also conducted and already been published. This was this year in April. Course study from 7 regions, and about 120 investigators were involved here. Outcome studies from trained the food healthcare professionals from 4 regions. We managed to get them outcomes over the year, and the manuscript has already been published. Afrodel studies is also being conducted in 10 countries, has already finished, and it is due to be presented in ESD this year in September. So the conferences, we had it in Malaysia, second in India, Southeast Asia. The third one was again in Malaysia, where I hand over to Harry. And the fourth one, Wahid has agreed to do it next year in May 2026 in Maldives. So this is today's webinar. 244 participants have registered from 68 countries, and this was checked last at 12 noon Central European time. So I welcome all the panelists, all the board members, regional chairs, regional advisories to the board, and guest panelists. Now we feel extremely honored and privileged to introduce speakers for this 8th and last education program for this term of year 2023-2025. Sicco A is a human movement scientist and professor of clinical biomechanics and principal investigator at the Amsterdam University Medical Center in Amsterdam, Netherlands. Sicco completed his doctorate dissertation on structure and functional aspects of the neuropathic foot in diabetes. In his work at the Department of Rehabilitation Medicine at Amsterdam UMC, Sicco leads and supervises research on lower extremities, biomechanics, and injury prevention in diabetes and sports. Sicco is a member of a board and program lead for rehabilitations and development of the Amsterdam Movement Science Research Institute. He is now chair of International Symposium of Diabetic Foot since 2024, and it's nice to have this webinar this series ending with him. He is member of Editorial Board and chair of the Ulcer Prevention Offloading Working Group of International Working Group on Diabetic Foot on Guidelines Development. Sicco is chair of Study Group of Neurovascular Complications of Diabetes in the Netherlands. He has approximately, which I managed to see was 212 publications, could be more than that. Manuscript have been viewed about 83,000, and citation of his publications 15,400. Some citations have been done. So we feel extremely honored and privileged to welcome our speaker, Professor Dr. Sicco A, for this 8th webinar program, Biomechanics and Offloading according to International Working Group Diabetic Foot International Guidelines. And all the questions can be posted on Q&A section during his talk and will be discussed later. Thank you. Sicco, it's all yours now.
Yes, thank you very much, Dr. Abbas, for this elaborate and kind introduction. Can you hear me and can you see my slide?
Yes.
Great.
Yes.
We can see your slide.
It's an honor for me to be invited to speak at this deep foot webinar on the topic of biomechanics and offloading. As I see, I'm the closing speaker of this series of webinars, which is very nice. And I see some very distinguished speakers before me on the different topics of diabetic foot disease. I do want to stress that me being the last speaker does not represent the phase during diabetic foot disease treatment that you should consider and start thinking about biomechanics and offloading, which is something that you should do at the very beginning of when a problem is occurring. And I will stress that and further explain that in my talk, which will be partly on the foot biomechanics. So what do we know about it and what is relevant in terms of diabetic foot disease, and then turn to what we have established as International Working Group on the Diabetic Foot in terms of guidelines regarding the offloading of foot ulcers. So I'm not going to talk about the prevention of foot ulcers, which has been done by Dr. Jaap van Nette before, but it's mainly related to my work in the offloading working group of the IWGDF. So actually, these aspects have already been mentioned by Dr. Abbas, me being member of the editorial board. I'm now the past chair of these two working groups that I'm affiliated with, so ulcer prevention and ulcer offloading. As mentioned, I'm the next chair of the International Symposium on the Diabetic Foot, which will be held in 2027 in The Hague. And I have several research funding, none of it commercial, but mainly through European and national grants. So an important concept in the area of clinical biomechanics is the relationship between the load on a given structure, a musculoskeletal structure, and the load-bearing capacity of that structure. And the load can be increased because people are exercising, for example, running, or they're unprotected when they are walking, or maybe because of a deformity that the load on a particular region increases. Or it may be the load-bearing capacity that is compromised because of illness, of maybe the healing of a particular injury or a foot ulcer that can occur. That is then causing a disbalance between the load and this load-bearing capacity, which affects the function of that particular region or structure of the foot. And in diabetic foot disease, it's mainly the mechanical pressure that is affected in a particular region and increases the risk for developing clinical complications such as pre-ulcerations, callus formation, and most importantly, a foot ulcer that you see on the left-hand side. So why is it important to study this in terms of development of foot ulcers and how we properly treat them? That is because every 20 seconds, someone in the world loses a leg or a part of a leg because of diabetes. So it's a very massive, prevalent problem. And if we look at the global burden, at this moment, about 18.6 million people are living with a foot ulcer, and another 130 million people in the world are at risk of developing one. And when we express the global burden of diabetic foot disease in terms of the years that people live with a disability, we see that when ranking from top to down, diabetes is ranked as number 6 of all conditions and illnesses and diseases in the world. Lower back pain is number 1. But if you isolate the diabetes-related lower extremity complications from the diabetes itself, it's by itself already ranked number 10. So a very large problem, a societal and also personal problem globally. A couple of years ago, colleagues of mine and myself, including Professor Armstrong and Dr. Tan and Professor Boulton, we wrote a review on diabetic foot ulcers and all the important aspects related to that, both the development and the treatment, in the Journal of the American Medical Association. And we were able to describe and also illustrate the mechanical pathway of foot ulcers developing in a patient who has diabetes and neuropathy. And if we look at that sort of pathway, this mechanical pathway, we see that there's different aspects of the neuropathy that will cause either loss of protective sensation because of the sensory neuropathy, or because of the motor neuropathy. There will be small muscle wasting, so muscle atrophy, foot deformities developing, and biomechanical abnormalities. And also from the autonomic neuropathy, we will see that there's decreased sweating and dry skin. And apart from just a small group of foot ulcers that develop purely because of a vascular pathway from peripheral artery disease, most foot ulcers in diabetes are caused by this neuropathic pathway. So from these different neuropathic systems and the abnormalities therein, we see that there's 3 mechanical pathways to develop a foot ulcer. One is through the continuous stress that is applied to the foot, where you have constant low pressure, for example, from ill-fitting shoes, which then creates ischemia in the capillaries, in the vascular system, and then ischemic necrosis. Most foot ulcers develop because of repetitive stress on the foot by being active. So it's a moderately increased abnormal pressure during weight-bearing activities that then result in callus formation and foot ulcer development. And there's also a possibility of high stress being caused by direct mechanical trauma, for example, from a foreign body in the shoe that causes a direct damage and skin breakdown. So this is generally the mechanical pathway of foot ulcer development. And here it's illustrated where you see that abnormal pressures on the foot are not felt during weight bearing because of lack of protective sensation, and you see callus formation developing. And underneath this callus, because of continuous inflammation and minor trauma occurring because of the increased pressures, hemorrhage occurs underneath the callus that when removed, when the callus is removed, we see the skin breakdown and we see a full thickness ulcer develop. So this is generally the typical development of a foot ulcer in a patient who has diabetes and neuropathy. And here you see, in terms of the relationship between this mechanical aspect in a condition where at least loss of protective sensation is present, how these regions where increased pressure is very nicely correspond to the regions where foot ulcers develop. So 4 examples, 4 cases where foot ulcers develop on the plantar surface of the foot in different regions, mainly in the metatarsal heads. The hallux is a very common region for plantar foot ulcers to develop, and also underneath the midfoot in terms of when Charcot deformity is present. And there's, as you see from the 3D images of the barefoot pressures, where the pink peaks are the increased levels of pressure, you see that those regions correspond with the regions where the foot ulcers are present. Now, what causes these high foot pressures in people who have diabetes and neuropathy? Callus was already mentioned. So callus can increase pressure underneath the foot with about 30%. So therefore, it's often removed by podiatry. Claw-toe deformity, which I will go in a little bit in more detail in a minute. Limited joint mobility increases the pressure underneath the great toe mainly. Equinus foot gives a very large increase in peak pressure underneath the forefoot. Specific changes in the tissue that can be imaged through MRI, showing increased pressures, partial foot amputation, which decreases the area over which the forces are distributed and therefore increases pressure. Charcot deformity, as mentioned, prominent metatarsal heads, inadequate footwear, and other changes in the soft tissue of the foot. And part of my doctoral work that I did about 20 years ago shows this mechanism of a sensory motor pathway of plantar ulceration in diabetic foot disease, where the motor neuropathy that you see at the top causes this intrinsic muscle atrophy, so the muscle wasting in the forefoot, where you hardly see in a patient with diabetic neuropathy any muscle tissue left, and most of the muscle tissue is replaced by fat tissue, which then causes an imbalance between the different muscles that exert force on the toes, and creating this imbalance both at the metatarsal phalangeal joint and in the interphalangeal joints, which then causes a claw hammer toe deformity. And as a result of this hyperextension of the claw toe deformity in the MTP joint, you see at the lower bottom that the protective fat tissue underneath the metatarsal head is displaced forward, leaving the metatarsal head more exposed and therefore increasing the plantar pressures underneath the foot when patients are active and walking. And this combination, as I showed, the elevated plantar pressure with then the sensory aspect of the neuropathy where people don't feel these high pressures, cause most of the foot ulcers on the plantar surface. So in many prospective studies, increased plantar pressure has been shown to be a predictive factor for diabetic foot ulceration. So there is a significant association where increased pressures cause foot ulcers. But if you look at the predictive value of these higher pressures, then these are not necessarily very high. So the sensitivity is 63.5%, specificity only 46.3%. And that is because the peak pressures underneath the foot that are measured are not the only biomechanical aspect that you can assess. And of course, the biomechanics is not the only factor causing the foot ulcer from developing. So it plays a role. There's a significant association, and we should treat these biomechanical abnormalities, but its predictive value is not necessarily high because many factors are involved. And we wanted to study this a little bit more in detail by, which is a PhD work from Chantal Hulshoff, a PhD student of mine who just a month ago defended her PhD thesis here in Amsterdam, where she looked at the total cumulative plantar tissue stress on the foot in people with diabetes-related foot disease. And it's cumulative plantar tissue stress, which is more than just a peak pressure value that you measure when doing a pressure measurement when patients are walking in a laboratory. Because patients are also walking in their home environment. They're wearing shoes. They're walking barefoot. They're taking stairs. They're also standing. We know that patients with diabetic foot disease stand twice as long as that they walk. So Chantal wanted to know and assess what is the actual cumulative plantar tissue stress, so the total load on the foot in a patient, and what is it? What are the contributions hereof? And here you see very nicely how the total cumulative plantar tissue stress is built up from the different activities and whether the patients are wearing their shoes or not. So at the top, you see 13% is explained by patients walking with shoes on, taking about 3,600 steps a day, and giving a 30% contribution to the total CPTS. But a much larger contribution is explained by patients walking barefoot, where, of course, the pressures are much higher. They take quite some steps, more than 2,000 steps a day walking barefoot, giving a much larger contribution of 39% to the total cumulative plantar tissue stress. People standing, where the pressures are slightly smaller than when walking, wearing their shoes, they do that 72 minutes a day, giving a 16% contribution. So even a larger contribution than the walking in shoes to the cumulative plantar tissue stress. And the barefoot standing, so not wearing the shoes, standing for 45 minutes, again gives a much larger contribution to the cumulative plantar tissue stress, so the total load on the foot, compared to wearing shoes and standing. So a very large contribution in these patients who are at high risk of developing these foot ulcers is explained by the fact that they are barefoot, not wearing their shoes, and being active, both walking, standing, and doing all other activities, even though the study showed that from the stair walking and the sit to stand transition that people make, the contribution is quite small, below 1%. So it's mainly the walking and the standing, wearing shoes, but mainly being barefoot, that determine the CPTS. And then 60 patients who we measured this with were followed for a year to see when and if they developed a plantar foot ulcer. And we found that cumulative plantar tissue stress measured at baseline was not a predictor of the plantar foot ulceration over time. Maybe because we measured the CPTS at baseline, whereas the foot ulcers developed maybe 9 months after, and we didn't have a measurement of the CPTS that was technically not feasible just before the foot ulcer developed. But what we did see is that the cumulative plantar tissue stress was significantly associated with the pre-ulcers. So the hemorrhage, the callus formation, the blisters that were present at baseline. So there was a strong association. And at the same time, we found that these pre-ulcers that were present were strong predictors of the subsequent plantar foot ulceration, which is confirming previous research that we did. And another factor is that we found that walking speed strongly predicts the plantar foot ulceration. And you may think this is an increased walking speed because that increases the load on the foot where foot ulcers will develop. But actually, we found that a lower walking speed is a strong predictor of plantar foot ulceration, which we explain by the fact that probably patients who show a lower walking speed are more vulnerable, have more comorbidities, and therefore have other reasons, other factors that will determine that their foot develops into a foot ulcer. So from this, we did not find this direct relationship between CPTS and foot ulceration, but we did find confirmation of the mechanical pathway that I explained in the beginning, where CPTS is strongly associated with pre-ulcer development, and pre-ulcers are strongly associated with the prediction of plantar foot ulcers. So now having these foot ulcers and knowing that the pressures on the foot play an important role, we need to take the pressure off when a foot ulcer is present. And over the decades, since the very beginning of diabetic foot ulcer treatment, many devices and interventions have been developed, both non-surgical, mainly non-surgical, but also surgical interventions, of which you see many here depicted. So the different casting modalities being non-removable or removable, being knee-high or ankle-high, different walkers that can be applied, both made non-removable or removable, different footwear interventions like forefoot offloading shoes, felted foam, custom-made insoles, which are all used for the purpose of healing a plantar foot ulcer. And also surgical techniques like flexor tenotomy and Achilles tendon lengthening, among others, have been applied and are applied. So if we look at the effect of one of the modalities, which is a very common one and also a gold standard treatment, the total contact cast, here we see a case of a patient who has a foot ulcer in the great toe, the right great toe, in a rigid toe, with some very high pressures, as you see on the left-hand side, in the custom-made shoes that the patient was wearing when entering the clinic with a foot ulcer. The patient was applied with a total contact cast, and you see over the right foot that there's a massive reduction of the peak pressures, where all these pink and red colors disappear because of the effect of the total contact cast. Mainly, of course, in the region where the foot ulcer is present, but you also see that in many of the other regions of the foot, the pressures are relieved. So underneath the metatarsal head and also at the heel. And that is because the total contact cast is very effective in reducing pressures because of the total contact principle to the plantar foot, where the area of force distribution is increased because of the accommodative nature of the cast, and the possibility to further modify the cast by applying pressures. For example, if there's a metatarsal head a foot ulcer, by further applying pressure proximally to that foot ulcer in order to relieve further the pressure underneath the forefoot. So a very effective way. And another aspect is the knee-high device, where already 30% to 40% of the total load that is applied to the lower extremity is picked up by the wall of the cast to the lower leg. So only 60 to 70% of the total load is actually applied to the foot, already giving a large pressure reduction over the total foot. Subsequent studies have actually shown that if you go from the conventional total contact cast, so the total contact principle of the foot, to even further wound isolation by applying padding material underneath the region of interest, which would be the high pressure region or the region where the foot ulcer is present, you can even get a more effective pressure reduction underneath that. So for practice, that often means that padding material, like felted foam or some other foam material, is first applied to the ulcer region, over which then the total contact cast is applied in order to get the most optimal and maximum pressure reduction possible. This is another example of a device that can be used for healing forefoot ulcers, which is a forefoot offloading shoe that has a negative heel and also a significant rocker bar that you can see at the bottom. And it's quite effective in reducing these forefoot pressures by distributing these pressures more to proximal regions like the midfoot, without necessarily increasing the pressures substantially in that region, because then, of course, they would be more a causative factor for subsequent ulceration, but also a mechanism using this negative heel and a rocker outsole to redistribute pressures in the foot and relieve the region of interest. And if you rank all these different modalities on which biomechanical studies have been done, you see that on the left. So how effective are they in relieving a particular region of interest from the pressure, the peak pressures on the foot? You see at the very bottom the total contact cast, which on average from the different studies that have been done can provide an 85% relief of peak pressure compared to a simple standard shoe. Above that are the removable walkers, so the knee-high devices. Then come the more ankle-high devices, and if you see more towards the top, athletic shoes and custom-made inserts provide about 25 to 30% pressure relief. So there's a very large range of pressure relief and offloading that can be achieved by the different modalities that are in practice used for healing these plantar foot ulcers. And if you then sort of overlay that image of pressure relief, the efficacy of these devices to heal these foot ulcers, you see that there's an association between the capacity to offload and the capacity to heal. So at the very bottom, the blue bars show the percentage of foot ulcers that heal in 12 weeks' time, which is shown by the TCC in 28 studies already, that about 85 to 90% of plantar foot ulcers, neuropathic plantar foot ulcers, can heal using a total contact cast in a quite relatively short time frame. So these are the green bars, about 40 to 50 days. And the further you go up, you see that the devices that are either removable or they are ankle high or are not casting devices give a lower percentage of plantar foot ulcers that can be healed in 12 weeks' time, and subsequently also a longer time to healing. So another way of showing the necessity of offloading, because the better you offload a foot ulcer, the more effective you're going to heal that foot ulcer. A surgical approach, which has become very popular also because more studies have recently been done on its efficacy, is digital flexor tenotomy, where the flexor tendon at the plantar surface is severed, quite simple intervention with generally toes that are hammering and that are semi-rigid. So they have the ability to still stretch, but they are hammering on the floor and therefore providing increased pressure relief. Either one toe or often at the same time multiple toes are tenotomied. And then here you see on the right-hand side, you see what the effect of that can be in a patient who has on the left-hand side a hammer toe, and some quite high pressures were depicted by the red arrow underneath the second toe, a very high pressure for the toe, which then after the straightening and the tenotomy is completely disappeared. So a very effective way to offload these toes, where we did a study in 50 toes in 19 feet of 14 patients, and the mean peak pressure at these toe regions of 430 kilopascal was reduced to 153 kilopascal. So a very effective surgical intervention to relieve pressure. Good. So now moving to the International Working Group on the Diabetic Foot Guidelines, of which you've seen many already pass in the previous webinars. The last round of updating was done in 2023. And on the right-hand side, you see the different topics on which guidelines have been developed. And the one that I'm going to focus on is the one on offloading. They are on the website of the International Working Group on the Diabetic Foot, so IWGDF guidelines.org. And there you will also find, but also in the literature, these two papers that are guideline document and the systematic review, which is the evidence of the different studies that we find as a basis, as a support to write the guidelines on this topic. And when we talk about offloading, it has a very long tradition in the treatment of diabetes-related foot ulcers. So from the very first start that we really started to treat these patients with diabetic foot ulcers, offloading was already known to be an important aspect of the treatment. Actually, one could argue that offloading is the most important aspect of treatment to heal a diabetes-related neuropathic foot ulcer. And also based on some more recent research, it is an important aspect in the treatment package to heal more complicated diabetes-related foot ulcers. So the ones that are infected or that are ischemic, but still have a neuropathic component. There may still be deformity present or a tissue that has a lower load-bearing capacity, so the pressures will be higher and therefore offloading is needed. But additionally, of course, the ischemia and the infection also need to be treated. And the offloading guideline working group that worked together in 2023 to develop these offloading guidelines and do the systematic review are shown here. So it's a very nice representation of people from different regions in the world, also from different professions. Who worked together, and I was chair of the guideline working group, and Pete Lazzarini was a secretary, who worked together for quite a few years to provide another update of these guidelines on offloading foot ulcers in persons with diabetes. And what was new for this 2023 guideline round? Well, first we had 14 clinical questions, or we call them also PICOs, to answer. So a little bit more than we had in the round before that in 2019. We added critically important and important outcomes. So we had a total of 18 important outcomes, where of course the healing of the foot ulcer is a very critical one, but also many other aspects of offloading treatment should be considered. So for example, what is the activity of the patient? What is the adherence to wearing a removable device? What are the adverse events that you encounter when treating patients? What is the health-related quality of life? Is there hospitalization occurring? What is the amputation outcome? What is the satisfaction of the patient? Because these factors will all determine whether a system is or a device is effective and whether a system can be used in clinical practice. Multiple meta-analyses have been done on several interventions because in several of the interventions that we studied, multiple randomized controlled trials had been conducted. We had new questions specifically on toe ulcers, on the contralateral limb, and also on education and offloading. And we had some new RCT data on surgical interventions. So the nice thing about the offloading guidelines is that we were able to summarize all the foot ulcers and the recommendations and the contraindications in one offloading pathway or diagram that you see here, where in red the type of ulcer is mentioned, in blue whether there's a complication or not, and then in green the recommendation is shown, and in yellow particular contraindications or other conditions of the patient. And let's go through each of these different types of foot ulcer, where by far most evidence has been collected on the plantar forefoot or midfoot ulcer that does not show an infection or ischemia present. Now, that may not necessarily be the most common foot ulcers that we see nowadays, but definitely most research has been done on these non-complicated plantar forefoot or midfoot ulcers. And the first choice treatment for this, based on all the evidence that we have collected and that we have analyzed, is to use a non-removable knee-high offloading device. That could be a total contact cast, non-removable, or a walker device that is made non-removable. It could be that these non-removable devices are contraindicated or not tolerated by the patient, and then the next level of recommendation is to consider using a removable knee-high or ankle-high offloading device and encourage patients to wear the device. So two things that you see here are different to this first step in the recommendation, where in the first step we say use a non-removable knee-high walking offloading device, and in the next step we say consider using a removable knee-high or ankle-high offloading device. Because we do not say now use, but we say consider, because the strength of the recommendation based on the amount of evidence that we found is just a little bit less strong. And another aspect that is different to the previous round of guideline development is that we have now written one recommendation for knee-high and ankle-high offloading devices. So in the previous rounds, they were separate. But based on these 18 outcomes that we have now been assessing, we do not necessarily see a big difference between using a knee-high or an ankle-high removable offloading device, because the one device may be more effective in terms of healing of the foot ulcer or preventing infection, but the other device may be more practical to use, better perceived, or increase the quality of life of patients. So put together, they are now in one recommendation. If these devices are not available, then the next step, so the third step, is to consider using felted foam, but never by itself, only in combination with appropriately fitting footwear. Also, a change to the previous rounds of guidelines is where a plantar foot ulcer is present on the plantar toes, where based on RCTs that have been developed over the last 4 years, the recommendation, if there's a toe ulcer on the second to fifth digit in a flexible toe deformity, to use a digital flexor tenotomy, as I just explained. So it's a first choice treatment for a plantar foot ulcer underneath the second to fifth toes. So not the hallux, not on other regions of the foot, but when they're plantar in the second to fifth toes, then the first treatment choice recommendation is to do a flexor tenotomy. Now, it may be that regarding these more metatarsal head and midfoot ulcers, that the non-surgical treatment is not successful. If that's the case, so if the ulcer fails to heal, then the recommendation is, in cases of a metatarsal head ulcer, to consider an Achilles tendon lengthening, metatarsal head resection, or a metatarsal osteotomy, all in combination with an offloading device. And if a hallux ulcer is present, the consideration is to do a joint arthroplasty, but also, again, in combination with an offloading device. Now, often the foot ulcer is complicated, so infection or ischemia is present. And if either of these are mild, so if there is mild infection or mild ischemia, then the recommendation is exactly the same as when there is no infection or ischemia present. So using a non-removable knee-high offloading device. If there's both mild infection and mild ischemia, or either moderate infection or moderate ischemia, then the recommendation is again the same as the second step in the non-complicated foot ulcer. So consider using a removable knee-high or ankle-high offloading device. Only when there is both moderate infection and moderate ischemia present, or one of them is severe, then the recommendation is primarily or first to address the infection and the ischemia, and use a removable offloading intervention based on the person's individual factors. So first treat the infection and the ischemia, but at the same time be considerate of what offloading should be provided, because again, offloading is needed also in these severely infected and ischemic wounds. If the foot ulcer is non-plantar, as I have explained in the beginning, there can be a biomechanical cause. So the recommendation is then to use removable offloading device, footwear modifications, toe spacers, orthoses, or digital flexor tenotomy, depending on the type and the location of the foot ulcer. There may also be a plantar heel ulcer, not very common when they're purely plantar. But the recommendation is then to consider using a non-removable knee-high offloading device. And the one aspect that was also added to the last round of the guideline development is what to do at the contralateral side. Because applying a total contact cast on the foot where the foot ulcer is may give imbalances and changes in the biomechanics where the contralateral side is affected. So the recommendation here is for treating of an ulcer and offloading devices used, consider using a shoe lift on the contralateral limb to improve the comfort and the balance while walking with the device. So we're not sure yet if that further reduces the risk of developing a foot ulcer on the contralateral side, but it definitely works in improving the comfort and the balance while walking, which is something that we still want patients to do. So we don't want to limit them too much in their activity, even though they have a plantar foot ulcers, but we do want to help them in terms of providing comfortable and safe walking. Okay, so then sort of to finish off with some key considerations when it's about offloading these foot ulcers. And the one consideration is that current practice, and that's what we see, does not necessarily follow the evidence. So we see that there's a gap. Sometimes it's small, sometimes it's quite large, between what this evidence, so what the guidelines actually show that you should do, and what is actually happening in practice. And there may be all kinds of reasons for why centers use different devices, different modalities, or different sort of clinical pathway to treating their foot ulcers, but we observe at least that there's a gap, and preferably this gap needs to be bridged. Another consideration is that there's many versions and type of offloading devices. So for example, what is a total contact cast? How do you really make it? And what are the different aspects to a total contact cast, either a walker or a particular shoe? And which one is the best? We don't necessarily know. And in the guidelines, we don't provide a recommendation on that because of the many different versions that we have. Few offloading studies have been done on complicated ulcers. So the vast majority of evidence is on the more the neuropathic non-complicated ulcers, but we see these complicated ulcers more in clinical practice, and we really need more offloading studies on them. Little focus is on the measurement and improvement of adherence to treatment. So we know that adherence is a problem. We see that adherence can be quite low, but how do we measure it in an appropriate way? And more importantly, how do we improve it? Surgical offloading interventions are not very common, or often we see only one RCT per surgical offloading intervention. So they still lack a strong evidence base, and we need more evidence and more repetition of these different surgical studies. We also have underpowered studies for the different complications that we see for using offloading devices, like the harms, the adverse events, the preferences of patients, and also the feasibility of applying that in a clinical setting. And cost effectiveness of an intervention is rarely reported, but it's becoming more and more important. So moving from the 2023 guidelines to the next round, the 2027 update we're going to write. So these guidelines are updated every 4 years. We have now made slight changes in the roles within the working group. So the 8 that were involved in the previous round are still involved now. So we're very happy that they are again willing to contribute their expertise to the development. But we now have a new chair. So I'm the past chair, and Pete Lazzarini has changed his secretary role to now being the chair. And Associate Professor Ryan Cruz is now the new secretary. And we have also 4 new distinguished experts on the team. Associate Professor Virginie Blanchette from Canada, podiatrist from Canada, Dr. Michelle Kaminski, podiatrist from Australia, Dr. Faraya Andrew, an endocrinologist from Tanzania, and also Professor Dane Wukic, orthopedic surgeon from the USA. So a very distinguished group that is going to be tasked with writing the next guidelines. And next week, we're going to have our first kickoff meeting. So these processes already start 2 years in advance because of all the work that is involved. I also want to draw your attention to the next International Symposium on the Diabetic Foot, which is an anniversary edition. So it's the 10th edition, and it's going to be held the 11th to 14th of May 2027, again in the World Forum in The Hague of the Netherlands. And it's going to be a special one because it's the 10th anniversary. And this is also the place where all these guidelines, again, are going to be presented and will be finished at that time. So not only the presentation on the guidelines, but also the guidelines themselves will be ready then. And of course, I want to draw your attention to the website of the International Working Group on the Diabetic Foot, where all this information can be found. So I would, with that slide, like to finish my presentation and thank you for your attention. And I'm ready to take any questions.
Thank you so much, Sicco, for the wonderful talk. It was clear, precise, and right to the point. Excellent presentation. It has been a real pleasure to have this series of webinars with you and your talk. Before we open the floor, welcome. Before we open the floor to question, maybe I can start with one question. How can we bridge the gap between evidence and practice for offloading foot ulcers?
Yeah, so as I mentioned in these key considerations, as maybe the most important, or at least a very important one, is this gap that we see. And we see this gap already 30, 40 years, and also already from the very first moment that we started writing offloading guidelines in 2007. And it's something where, of course, these guidelines, they develop and new evidence is added. But for a certain part, they're quite the same. So the total contact cast or the non-removable knee-high walker are still the gold standard, are still the first choice treatment. And we see in practice, and others have assessed this already in studies, that these are not the most commonly used devices. And somewhere it's understandable from a point of view that where these techniques are not available, or patients may be not willing to take these to use these interventions. But at the same time, there's of course a responsibility to provide the best offloading solution for these plantar foot ulcers, knowing that the more offloading you provide, the better you can get, and the sooner you get these foot ulcers healed. So there is some tension in this respect, where I think the way to bridge it. I mean, it's a difficult question. Of course, I don't have the definitive answer to that, but I think we should look more into, okay, so what is happening now in clinical practice? Why are some centers still using very actively these first choice treatment modalities, and others very quickly or substantially move to other kinds of devices, and see what's going on there and what are the outcomes that they find. So I'm quite sure that many of these centers, with all the experts present, do not choose to use a inferior offloading device because they simply like to do that. So they hopefully and expectedly have some good arguments for doing that. And we would like to know what these arguments are. So, and also when you deviate from these guideline recommendations, what is the reason to deviate from it? And if many of these aspects are related to things that we are now adding to the guidelines, like these different outcomes, like health-related quality of life, feasibility, applicability, etc., then these are important aspects to consider in the treatment regime for plantar foot ulcers. And maybe the solution towards the future is that more combination. So the first thing is having data that we actually know what is being used and what the outcomes are. So we can start comparing, we can start benchmarking, we can start finding out which patients are provided with which kind of modalities, and then see if maybe combinations of modalities would be a more appropriate solution to both sort of address the fact that we have guidelines and we have different levels of recommendations, and we have a practical situation where other aspects are important. And a nice thing is that we got some nice funding to start a multi-center trial here in the Netherlands, which is called Shoe Off, where we want to develop a protocol that addresses these different aspects. So the evidence on the one hand side and the practicalities on the other hand side, and see if we can, with all the clinicians involved, develop a protocol where we're actually bridging a gap like this. But it's a difficult one, and it's one that has been present for decades already.
Thank you, Sicco. I had other question, but I think there are a lot of hands and questions in Q&A. So Professor Shakavi, followed by David, followed by Vijay. So let's start with Professor Shakavi. His hand is there. Yeah.
Thank you very much for the wonderful presentation. I just have some concerns. Please understand it and reply to me. Number one, the mechanical offloading. You didn't say for ulcer 1 centimeter, 2 or 4 or 7. And then if there will be healing, the healing will be by weak scar tissue. If happened that it's vulnerable to recurrence nearly 100% in my series. Especially, you didn't treat the offending bone deformity, which did this injury, because the ulcer is due to pressure from the deformed bone over the skin without the muscle bulk and the ground. And so you didn't touch the bone. And so if there is healing, it will be fibrous tissue, which is weak to have recurrence nearly 100%, and the insulting bone is available. And so the incidence of recurrence is very high. And as you know, the plantar ulcer, neuropathic ulcer, we consider it as timed bomb in the foot. By the mechanical evaluate by the mechanical shoes pressure elevation, it will elongate the time, but will never prevent the bomb, because these ulcers have many factors for heel retardation, not only the bone, maybe blood quality factors, hypoalbuminemia, anemia, dehydration, infection that can happen within the long period of mechanical offloading. And the result is very weak scar tissue, not liable to ulcer. In my series, 100% ulceration, except we do surgical offloading to the bone, to the extent that in our series, we started by this way and we found that very bad results. So we started with mechanical offloading for a week to prepare the patient to control the wound care for the factors for wound healing to be corrected all through, then to do the surgical offloading, then to put mechanical offloading again. Surgical offloading will remove the bone, will debulk some tissues, will make the skin approximation easy. And so the scar tissue will be minimal and the healing power will be much better than leaving an ulcer like that with very weak scar tissue. I don't know what is the incidence of recurrence in your series.
I think you address
Yes, Sicco.
you address an important aspect, which of course I didn't touch on because it was now about offloading of the foot ulcer, but is the recurrence. And you may have a 100% recurrence rate. We know from the literature that the average recurrence rate after healing of a foot ulcer is 40% in 1 year. So even though that's not 100%, we still consider that very high. And the highest risk of developing a recurrence is directly after healing one, for the exact reasons likely that you mentioned, that the foot structure has not changed. So the ulcer may have been healed because of very appropriate offloading, but then the structural aspects of that foot, whether it be bony deformity, whether it's soft tissue quality, likely have not changed. Well, the bony deformity you can assess. The tissue quality is something that we don't know a lot about, but we're doing actually a project on that, an imaging project, to assess in this remission phase directly after healing what the quality of the tissue is and how it develops. But these factors significantly increase the risk for the recurrence. But we still know that a mechanical factor needs to be present to develop that foot ulcer, whether it's the first ulcer or a recurrence. So we should always work on a mechanical offloading, whether it's for healing purposes, but then just as important for the stage after that, when the remission stage when there's an increased risk of ulceration, very appropriate modalities need to be provided, mainly using footwear, but there's also other aspects of treatment that need to be involved, such as the education of the patient, the self-monitoring and management of patient for warning signs, etc., because this is such an important phase of the disease with very high risk of developing these problems. Surgical interventions may improve the situation. We also know that from the literature. Actually, the literature shows that these surgical interventions like Achilles tendon lengthenings, osteotomies, I'm not sure about the flexor tendinotomy, but these are actually more effective in preventing the recurrence than they are in healing the foot ulcer to start with. So yes, for specific cases, this may be a very good additional treatment plan. Not for everybody, but definitely should be considered in the whole sort of package of interventions, not only focusing on getting the foot ulcer healed, but also preventing its recurrence. So good additional point.
Thank you, Sicco. David, your question was there. You want to put comment before I go to Vijay?
Yeah, I'll be super fast because I think Dr. Shikawi his point was really, really important. And I know Sicco thinks about this all the time as well. These patients are in remission. And so the chances of them recurring, if you spend enough time with them, hopefully you're with them all the way, is almost 100% if you cumulatively add up the best available data we have. But as you heard, there's about 40% at 1 year, 2/3 at 3, 3/4 or so at 5, depending on how you look at the data. But so that point and about surgically intervening is really, really important. But quickly on the same point, it was really tantalizing those data that you showed early on in your talk with Dr. Holsoff, your PhD mentee. That is duplicating a lot of the work now and extending a lot of the work from Mike Miller and Dave Sinecor and others from a generation ago now. Can you say what you're finding now that's different from Mike Miller and Dave Sinecor, and where you and Dr. Holsoff see that going? Because Bijan has been preaching this for the last 10 years as well, from some of the data we had from Qatar, the Qatari data showing that unprotected standing seems to be really associated with recurrence and with poor healing. Anyway, this is a fun time to be looking at these data. I will now shut up.
Yeah, and nice that you mentioned this, and it's a good opportunity to go back to that data, because it's the reason that we started this study was that I saw this the biomechanics playing a factor in the development of these foot ulcers. We know that if you look at it in different angles, also based on the healing of the foot ulcer and the necessity to offload, but we were still not very accurate in predicting where that's of course something that you would like to do. You would like to assess particular aspects about that patient and determine what the chances are of developing a foot ulcer. And maybe before that, at least try to explain why they developed. So we took that data from Muller and Sinecor and looked at the way that they measured the cumulative plantar tissue stress, and tried to improve on that model by involving even more activities. So the standing activity, the chair, the stair walking activity, and using different models. So one of Chantal's projects was about defining what the most appropriate model is to study cumulative plantar tissue stress, and then apply that in this group of 60 patients that we followed over time for a year. And again, we did not find that having a more comprehensive model of the biomechanics improved on the prediction of these foot ulcers. We found some very interesting other aspects, like the lower walking activity or the lower walking speed, and again confirmation that these pre-ulcerative states of foot ulceration are very important predictors of outcome, and that gives you an opportunity to intervene quickly when you identify these pre-ulcers like abundant callus and blisters, etc. So clinically still very important, but it's a continuous search for how we can improve the biomechanical model of foot ulceration in these patients, considering or still realizing and accepting that it's not only the biomechanics that will cause these foot ulcers. Like already mentioned, the disease factors of diabetes will likely be involved. The behavior, of course, of the patient is very important. So we don't have the intention to create a perfect prediction based on the biomechanics of how these foot ulcers develop, but we want to improve and we want to sort of grasp. And now another student is doing a more fundamental analysis using machine learning on the data that we have, to see, okay, can the machine learning find any kind of factor that we cannot do with our normal regression analysis, or that we see as scientists or clinicians in the data, to improve on this outcome. So anything that could help to improve would be better. And well, some aspects of the study design I already mentioned that may be a limitation from the point of view is that we at this moment are still not able to measure the exact biomechanics the week before the foot ulcer develops. Because that's, of course, something that you want to know. What is happening in those few days or week weeks before the foot ulcer develop, because there may be a change in the biomechanics. There may be a change in the behavior of the patient that will then cause his foot problem from developing. But at least we took it to the next level and improved on the understanding. And how research goes, that multiple questions still arise from those kind of outcomes.
I love it.
Thank
And
Yeah.
by the way, though, I'm sorry to interrupt, but that this is an important advance. I mean, looking at in-shoe, I mean, you had what, 77 minutes and 45 minutes
Yeah.
of in-shoe and barefoot standing. I mean, that has not yet been,
No.
characterized yet. And this is
Yeah, and this again, nice that you mentioned it, because that was also still, even though we know that adherence is not always high in these patients, and these are high-risk patients, so they went through an episode of foot ulceration, and we see, wow, just looking at the standing and the walking activity barefooted, so not wearing the shoes, how much this really contributes to the cumulative stress on the foot is again, I wouldn't say an eye opener, because we knew that this was already the case, but it very nicely confirms and maybe even shows that this contribution is even bigger than we thought it was.
Thank you. Yes, Vijay, you had a question.
So, my question was, why would is total contact cast contraindicated if you have an ulcer, active ulcer with ischemia, or if you correct the ischemia, fine, you do a revascularization, you correct the ischemia. But is it still contraindicated to use a total contact cast? I've asked this question to David, and David said you could use a removable cast with a tape around so that you won't remove it. So if you want to examine the wound every day, would you use a total contact cast? And that's one of the questions of us in the chat box.
If there's a neuro-infected wound, then of course you need, if there's infection present or ischemia, you always need to treat the infection and the ischemia. But that does not mean that offloading does not have a place in healing these foot ulcers, because there may be just as well a mechanical problem in combination with the infection or the ischemia that should still be considered. And for that, we have these sort of different steps of offloading that you provide. But of course, and in particular when it's moderate or severe levels, you need to treat the infection and the ischemia first. But only doing that and not providing any offloading will compromise the healing.
Thank you. Thank you very much. I think we're running short of time, and time is never in our favor. Sicco is also busy. So we would like to extend our heartfelt thanks to our guest speaker, Professor Sicco Bus, for taking time out of his busy schedule to join us today and deliver such an insightful and important lecture. As you heard, there are so many questions still, but thank you so much, Sicco. Thank you. Thank you. You are free, and we will continue with our sponsor. Thank you.
Yes. Thank you very much, and happy to contribute.
Thank you.
Thanks, Sicco. Take care. Bye-bye.
Before I hand over to Harry, I would like to again take a moment to express my deepest appreciation to everyone who has contributed to success of DFoot International during my term, to the outgoing and incoming boards, regional chairs, advisory boards, the country representative, and all the members of DFoot International. Thank you very much for your delegation and ensuring our programs running smoothly globally. I would also like to thank my secretary at DFoot International, Zaima, for her outstanding work. Thank you. To our newsletter coordinator, and this Raida, and our website manager, Muhammad Abbas, to manage our communication and presence daily. on daily basis. Thank you, both of you, for excellent contribution. DFood International is deeply grateful to our sponsors, even today, for their support for over the past 2 years, and we look forward to continue their partnerships. And finally, to all the delegates, your participation is what makes these activities possible. A very big thank you to each one of you from bottom of my heart. I am now very pleased to hand over to Professor Harry, who will introduce our sponsors' talk and later deliver the last vote of thanks. Harry, it's now over to you. Harry.
Thanks, Abbas. Thank you very much. I think we would like to thank, Prof. Sicco A. And the good thing is the next topic is also something which was actually launched, and myself and David actually chaired this session during the meeting in the ISDF in The Hague in 2023. So for this session, basically, Professor Yuran Ko, who is actually a consultant plastic and reconstructive surgeon and also a professor of surgery in Kaohsiung Medical University, Taiwan. He's also a member of the executive board of the World Union of Wound Societies. So he'll be presenting about macrophage modulation, a new paradigm in wound healing. Now, previously, all this while we'll be talking about matrix metalloproteinases, but anyway, in 2023, they basically launched the usage of macrophage regulators. So, Professor Yurenko, you have the floor. Thank you.
Yes, since Harry is introduced, I want to share my slide. Yes, could you hear me?
Yeah.
Yeah, okay. Firstly, I'd like to thank the society giving me this chance to talk about this macrophage modulator new pharmacology shooting for the wound healing. And I'm Yoren Kuo from Taiwan Kaohsiung Medical University, and also as the in charge pneumonia society, as well as the honorary president of Taiwan Society for Wound Care, and will be the president-elect or Asia Pacific Association of Diabetes Problem, also as the executive board committee, as the WHS with Professor Hari, and as also in charge of numerous editor board in scientific journal, PIS, the International Wound Journal, Microsurgery, and etc. As we know, that's the. Do you see the slide?
Ken, proceed.
Yeah, okay. And as we know, that's the advanced wound technology. Except the past, we use the traditional topical agent, and also numerous company from apply different topical dressing. And some advanced has been addressed, such as cell-based technology, such as stem cells, or some numerous extracellular matrix scaffold, or MPWT or topical oxygen. But today I want to address one new drug that is talking about the macrophage modulation. As we know, during the wound healing, the macrophage actually play an important role, especially for the chronic wound healing. Because during that diabetic ulcer is undeterred remain inflammatory phase during the wound healing process, and also the local macrophage they retain the pro-inflammatory characteristic during the healing process. So during that, the local macrophage is important during we are in the healing process. But this type from our in vitro and in vivo study, we found that if we can moderate the M1, the macrophage type 1, just per inflammatory cells, and subsequently activate M2 as the anti-inflammatory to matrix depollution and increase the angiogenesis properties will lead to the tissue repairs. So do that, we can elevate if I have one new byproduct, can elevate the macrophage to shift to the M2, the bracket transposition. There will be a new treatment strategy to treatment chronic wound healing. So that's the mechanism that has been addressed in the past few years as the macrophage has actually involved the chronic wound healing and also shift their phenotype from the M1 to M2. You could find that actually can enhance wound healing. And what is this new topical regulatory pharmacology agent? It's we named as ON101. It's composed of two clinical significantly formation composed ingredient. One is from the protransers umbilicus. The other is from Centella asiatica. That two plants has its good to mix together and they have a track as a safety and efficacy in wound healing from the best the preclinical to clinical study. So during that mechanism, the true as we mentioned before, is that can suppress the M1 phase during the mature and shift to the M2 transitional phase, have an anti-inflammatory response and increase the tissue remodeling. And based on the evidence base from the case series to systemic review, actually there have numerous study has been mentioned and published that such ON101 has some clinical evidence through the macrophage regulatory effect to enhance wound healing. And that's in the past, from the random controls study. Actually, from this study, they have mentioned the patient as around 236 patients, and in that random control study, and the major is Wagner class 2, grade 2, 10 to 80%. As such protocol, we find the patient actually compare with the traditional dressing with high hydrofiber, we find that's around the 10 to 2 times faster the complete wound healing with the traditional hydrofiber. And also, that they have some evidence they find is that ON11 compare with the advanced wound care, such as they have a regenerated template, the skin graft, a flap, or several foam dressing, compare with that treatment. We can find actually they can have a good effective to promote the wound healing. On the other approach, we use the infected diabetic foot ulcer together with the other treatment group. And the other also use the historical data compare. You can find a follow-up around the 4 months actually give the ON11 group, they have a true increase the wound healing, even that's in infected diabetic wound ulcers. And you find that's the in some amputated incidents after the treatment with 101 compare the advanced treatment group. Actually, the 1 year post-treatment, they decrease the amputation rate. Even such case has a severe POD or infection case, the percentage is significantly decreased after apply the ON11. It means that maybe the ON11 modulate the M1 to M2 macrophage and continue to have effect to increase the wound healing. So based on such evidence, in the past, we also have some experience. And in a 10-way tough case as type 2 diabetic patient, they actually an healing wound persist Some has more than 6 weeks, and also they're grade 2 to grade 4 in loading. And the wound size we actually run to by 3 to 10 by 6 centimeters square. And after there's infection and debridement, and also if they have ischemic limb, we do the angioplasty intervention. Then we start to apply the topical macrophage, the greater as ON101 in such wounds. And they actually is per day 1 or 2 times during that period around 18 to 200 days. And all the patients they have one here and eventually without notable side effects, except one patient that failed result with slow progress. And during that period, the patient they received debridement, secretotomy, and treatment necrotic scar tissue. And two cases they still need to do skin graft after granulation tissue. And then also the other case, we are doing follow-up. None of the patient had need to amputate it or had further complication. And the patient all certified their result. I will share some very tough case, such this female, that both them has severe gangrene change, and after angioplasty, if during that before angioplasty or intraoperative angioplasty, but it's very hard to pattern to pass through the below knee region area. So after that, with multiple treatment, debridement, and even we do a couple times PRP inject first. The wound still adhere. After that, we try to apply the ON11 first. So do that, we start to apply the treatment, the ON1, the photo. And you can find just 2 weeks, there's some granulating tissue that grow up and epithelialization faster than before. And the 4 week, one leg, they wound almost complete here. The other, even they have ankle exposure, the joint exposure, the treatment, they also have granulation tissue grow up. And that's a 3 months follow-up, they all here, the treatment after the ON11. In that case, also 65-year-old female, they have severe POD, DM, hypertension, and you look at that's a tendon or necrosis. In the past, we also recommend a patient, actually you need to do the amputated to below knee. And actually we do the angioplasty first, but you look at that almost 100% occlusion in that region area, but we have a success to pass the angioplasty first. And during that, we start to debridement. Even they have tendon necrosis, we put the artificial dermis first. And after that, we have some necrotic tissue, we trim it, and we continue to use the ON11 topical agent. And the necrotic tissue in that surrounding area, and you look at that, and when they slowly progress healing acceleration. And final, that's the partial tendon necrosis region area with debridement and remove it, and the wound can complete here. And even the range of motion of ankle, we still can keep it. And the other case is the patient, the severe diabetic foot ulcer with acute tendon exposure and some bone necrosis. And after that is a heavy smoking, and with debridement, secretotomy, and we use the topical papilla arterial artery preventer flap cover different area. However, there's the tip of the flap region is a partial necrosis, and also they have calcaneal bone has a partial, and also the acute tendon partial exposure. After that, we debridement, we start to apply the ON11 in that region area. And you look at that, 1 month after treatment, the wound they decrease and some granulation tissue, actually they can grow up. And then after 2 months, they almost complete here until the 3 months, the wound complete here in such a very difficult case. So not just apply the diabetic foot ulcer. Recently, they still have some clinical trial has been a study even use the pressure ulcer or even the post-surgical wound or radiated with dermatitis or even the burn wound have a start to apply and also have some positive effect and published in their pilot study. So I just want to make a short conclusion. Actually, regulated macrophage, it's a new treatment based on our clinical evidence for diabetic foot ulcer. And the topical, the macrophage regulation actually is effective to chronic non-healing diabetic foot ulcer. Even some very challenging case and fail our traditional treatment, we still have a chance to apply and rescue the limb. Thank you for your attention.
Thank you, Professor Yorenko. Any questions from the floor? I think Prof. Shakawi, I think you have used it
Yes.
in Egypt also. Can you give us
Yes,
experience?
yes. Really, I used this type of treatment. We have been offered this treatment for a patients. So we have a group of 100 patients. We used this cream, and others we used the regular cream we are using. Of course, after agreement of the health insurance and the patient volunteers. Then we used our protocol to detect all the etiological factors for the ulcer, whether blood quality, quantity, bone, ischemia, anything, and it's corrected. After that and before, we used that cream on both groups, different types, and this one. Really, because I'm vascular surgeons, I don't see the macrophages too much. So I believe in practice. After using this, really, we found that the rate of healing is very fast by this ON101 was very fast, really, as compared to others with the traditional cream used. This was not good only for the fast healing, but also good for the long period. So with that cream, the healing was from 3 to 6 weeks. By others, it was from 2 months to 4 months. And so the long period of ulcer presence, the patient usually will have many mishaps that necessitate hospitalization and treatment, like hypoalbuminemia, anemia, dehydration, infection. And so the treatment is usually longer. Mishaps are too much. And the end result, the incidence of limb loss is higher than the using this cream, which give a fast. Really, we went in the electron microscope in Cairo University to see that macrophage. We found that really it's much more after application of this cream than others. And so we did this trial, and we are waiting now for the results to be published. Thank you.
Thanks.
You
The Professor Shakawi's share.
said the indications for using this macrophage therapy. Can you tell us the indications? Because there are multiple things to be used in diabetic foot. Can you tell us the criterion which is useful for clinicians, surgeons to use this product? Professor
Yes,
Yu.
and thanks, Vijay. That's a concern about this. During the past, the random control study, they focused on the Wagner grade 1 and grade 2 case. But during that, in our real world data, we did not limit the apply to even Wagner grade 3, grade 3 or grade 4. But first, we need to do the debridement first. We need to do some necrotitis, remove it. After that, we can apply this topical agent. even they have some bone exposure, it still can apply to protect. And according that's the infected wound, you in the past you still need to control together with the systemic antibiotics. But during the infection, you need to also treat some infected tissue in the peri-wounding region area. Then you can start. But if that drug actually is increased, the granulation tissue growth from our patients' clinical experience and also from the some literature, we found that so that's drug. But I don't think that's the only one way to pharmacology shooting. But during our limited experience, we think that it's the change, our past, the thinking for the topical agent to apply the diabetic foot ulcer. That should be another new strategy to promote the wound healing.
Thank you, Professor.
Thanks.
We have one question basically in the section, the Q&A side. What is the topical macrophage modulator cream application protocol? Is there any specific protocol per se? I mean, other than debridement and basically looking at all the other factors, basically. Is there any other protocol?
Actually, that's the not the true standard protocol, but during that protocol is the and for the random control, we need to still need to control diabetic, the sugar we need to control, and also have infected. You still need to control the use of systemic antibiotics. But before we apply this drug, if that's a ischemia, severe POD, you still need to do the angioplasty first. But for the clinical, in the past, in our study, the patient is we use the traditional pharmacological shooting or topical dressing. They invent and then we start to use the ON11. But I think in the future, we can just after deployment, it should be shipped as a first line. You can try to apply. So, but I did not have a true, that's the standard. Maybe in the future, more clinical evidence, we can write down as the true guideline, what's the true indication to apply. But till now, the numerous evidence there's no, if not a true infected topical wound region area, you can directly apply.
Yeah. All right, thank you. I think due to what do you call this time constraints, is there any last burning question from anyone or comments?
Terry, Wahid's hand is up.
Okay, Wahid, yes.
Yeah.
Yeah, thank you very much. Actually, my question is regarding the frequency of application. You have mentioned we have to apply twice daily. So I was wondering, so every time when we apply the 101 cream, we are going to do a dressing, means we do cleansing and then do dressing again. So would it affect reducing the wound healing? I mean, slowing the wound healing, because sometimes frequency of dressing also reduce the speed of wound healing. Any comment on that?
Yeah, thanks your concern about this. Actually, is that we recommend is that once per day or twice per day, depend on the wound area. So regular is that we let the patient, educate the patient just once per day. That's enough. But if that's true, a lot of discharge, you may shift to twice. So regular is once per day. That's enough. Doing topical in that wound region area. We know that you mentioned that too frequent, some epithelial cells, they may be damaged. So during that, so we totally agree.
Okay, so I think once daily is better, because the thing is, I think the other aspect why Dr. Wahid is asked is because you have to see the patient twice a day, or sometimes in some places they might have to visit the patient, if unless the patient does the dressing by himself. But twice a day it's a bit more cumbersome. So once a day is a bit more better. All right, thanks. I think if there's no other questions per se, I would like to thank Professor Yorenko for his excellent talk on the usage of macrophage regulator, which is so far the only macrophage regulator in the world which has been identified now. And there's quite a number of studies on it, basically, and also has been presented in The Hague as well. And also, let me thank Oneness Bio for their support for this webinar series, and Prof. Abbas for doing a wonderful job for the past 2 years, 2023, 2025. And he's not going anywhere. He's still basically just there, just changing slightly a name there, basically putting immediate past in front of it, which is just IP only, basically. It's like an investigational procedure kind of thing or protocol kind of thing, that's all. So with that, also thanks to what do you call this, Dr. Vijay also, who is also not going anywhere. Basically, I mean, all of you all are still here. It is just a slight change, a name change in the organizational chart, which basically what do you call that is more for the books. I think in practical aspect, basically all of us are together, and I think for the past 6 years has been a wonderful session. And together with the new board, I mean, Dr. Wahid, Jolene, and everybody else, and Salma also was here. And then same time, what do you call this, to regional chairs and all the groups, okay, the Shakawi and all the teams from all the regional side. It's a pleasure to have you all here. We will be in touch. Anyway, the what do you call this? The webinar series will proceed every 3 monthly, basically. Only thing is, after this, since you've already covered the whole IWGDF, we have got another 2 years where we'll cover all the regions now. So, as presented by Abbas before, the 7 regions basically will be presenting each session after this. So we'll send you the list basically to get that. And then at the same time, basically, we will also, what do you call this, add in additional lectures into every session there, maybe short 10 minutes, 15 minutes sessions, so that, what do you call this, even the industry can support us better. So we can do more things. All the rest of things that Abbas has already presented is already, has been done and will be continued. There is no reduction in any of these things at all. It is just addition to whatever is there. So that's the actual plan, so that, we continue to grow instead of, maintaining it at one stage and changing it differently and all that. So I think we are quite happy with all the editorials and everything else. So with that, I would like to thank all of you, especially all the delegates and all that. And we will also try to boost the numbers after this also, so that more regional people can come in. Because now, if you know, in November, our meeting is only going to be one day on the 14th of November. So the rest of the regions will be meeting every 3 monthly. So that 3 monthly session webinars, basically, where each region will present, basically, in English. We will get, what they call is, the world to hear what is happening in Saka, in Naka, in Europe, and also in other places and all that. So that will be good. So all of us are together. So with that, thank you very much. And also to our sponsors, Ergo, Oneness Bio, and everyone else who has been supporting us, and who we hope will continue supporting us as we continue to prevent avoidable amputations. And also with our close friends, basically with IWGDF, as now we have Fran Game, the chair of IWGDF, inside the board of DFood. The marriage is complete now. We are back together completely. We are not only an implementation arm, we are together. So that is the best, thing that we have got. And he was really happy. I mean, I'm really happy that we got her on the board also. So with that, thank you very much. Have a superb weekend. And most important thing, don't forget that you all are doing a great job. And I cannot tell that again and again. God bless all of you. Take care and have a wonderful weekend. Thank you.